Welcome back, everyone. We're going to continue the discussion on neonatal and newborn complications and emergencies. Another emergency that we may encounter or need to be aware of are seizures in the newborn. And seizures in the newborn suggest the presence of a neurologic disorder. They're usually related to an underlying abnormality, and prolonged seizures and the corresponding hypoxia can cause significant brain injury. Types of seizures that we may see in the newborn, we may have myoclonic seizures, spasmodic seizures, tonic seizures, and subtle seizures. And seizure presentations for neonates don't always present in a manner that you may be familiar with. They could be focal, generalized. They could be stimulus sensitive or triggered by certain types of stimulus and create a seizure. We also need to be aware that seizures can emulate, or ALTs, apparent life-threatening events, can emulate seizures as well. So we need to be concerned about the risk for the long-term risk for SIDS or ALTs, where the neonate or newborn may be at significant risk for other morbidity and subsequent mortality. So transportation and communication with that receiving facility is going to become important. For assessment and management for seizures in the newborn, evaluate prenatal birth history, physical exam, vital signs, additional oxygen and ventilation assisted as needed. Make sure you're assessing blood glucose as well. Blood glucose levels less than 40 milligrams per deciliter. We're going to use IV bolus of dextrose 10%. We should never, you really shouldn't be using D50 ever anyway. D10 is a much better medication for the treatment of hypoglycemia, but you absolutely should not be using concentrations of dextrose higher than 10% for neonates, infants, or children. Make sure you're monitoring respiratory status and oxygen saturation, and again, normal body temperature. Keep room warm, keep baby warm. Hypoglycemia in the neonate can result in seizures and subsequent brain damage. Birth to 4 hours of age, you're generally looking at blood glucose levels of 25 to 40, and then after an hour should be somewhere around the 35 to 45. Target glucose should be above 45 milligrams per deciliter. Risk factors include disorders related to decreased glycogen stores. Remember that neonate doesn't have, and newborn doesn't have glycogen built up in the liver, that just haven't had time for that to be utilized yet. So the compensatory tool for hypoglycemia isn't present yet. Likewise, glycogen dumping medications like glucagon or glucagon aren't going to be effective in neonates, infants, and children as they are in adults. Symptoms can be nonspecific, right? Check blood glucose levels, maintain adequate glucose levels, encourage feeding, right? That's a much better way to get glucose if baby's responding to feeding. Assess for hypoxia, right, and normal body temperature. Hopefully this is sinking in now. Vomiting is common in newborns. It can be persistent or bilious vomiting for the first 24 hours, can indicate there's upper digestive tract issues. Also of concern, increased intracranial pressure. While not the most likely cause, your index of suspicion should be there, and you should always be vigilant for signs of abuse and neglect as well. You should be in tune to those things. Causes of vomiting can be esophageal atresia, reflux, which is really common in neonates and newborns. Less common causes can be things like malrotation, congenital conditions, or IHPS. Sudden, unexpected, and forceful vomiting can occur in conjunction with meningitis, hydrocephalus, and asphyxia. Part of your assessment should be assessing temperature and assessing for infectious agents. And then, obviously, asphyxia and head trauma, secondary to abuse, neglect, or trauma in general, should also be on your radar. When you assess, the stomach may be distended. Patient may or may not have a fever. They may be hypothermic. You may also note temperature instability, bradycardia, which would indicate hypovolemia or possibly increased intracranial pressure, abdominal tenderness, and guarding. Assessment and management, right? ABCs. Consider inserting an OG tube or an NG tube for decompression of the stomach, should your protocols allow. Do not administer antiemetics. They may need fluid resuscitation for hydration, and place the newborn on the side when transporting if possible. Diarrhea creates an excessive loss of fluid and electrolytes and can come from things as simple as gastroenteritis or lactose intolerance to things like poisoning and neonatal abstinence syndrome. Try and estimate the number of volume lost. You can do this through history. Inquire about size of bowel movements, number of diapers per day, how frequently is caregiver changing diapers, and compare that to their normal rate of change. Look for things like decreased urinary output, right? That would be the presentation of dehydration, and baby may need resuscitative measures there with fluid. Consider neonatal jaundice is another thing we need to be aware of. It's clinically visible in the first 24 hours, and this is when the serum bilirubin increases more than 5 milligrams per deciliter, or when the bilirubin exceeds 12. Conjugated bilirubin makes up about 20% of the total serum bilirubin concentration, and clinical jaundice persists for more than a week in full-term infants or more than 2 weeks in preterm infants, and it's graded on a scale of 1 to 5, depending on where the jaundice is. As far as assessment and management, transport is going to be essential here. There's going to be further tests and assessment that's going to need to be conducted that we don't have the capacity to do in the pre-hospital world. If they're showing significant clinical jaundice, right? So extended period of time post-birth, then you may consider starting some IV fluids, but you should be communicating with online med control and receiving facility and gauge the level of treatment. Thermoregulation, limited in newborns, right? Average normal temperature for a newborn is about 37 degrees C. Ranges from 36.6 to 37.2. Heat loss is important. They radiate heat off to the air. If air is moving across them, you've got convective cooling, you've got evaporative cooling, and conductive cooling for laying on cool surfaces. So you need to be mindful of keeping baby warm here. Fever in the neonate newborn is a rectal temperature greater than 38 C or 100.4 Fahrenheit. Newborns may not always present with a fever. Remember that the immune system in the neonate is not fully developed. It takes a couple of years before baby develops its own immune system. It's working on mom's antibodies during those first couple of years of life, and this can create some convolution in the presence or the persistent symptoms that would normally exist with an infectious patient. So fever is not your end-all be-all, but a fever would definitely indicate potential problems. Not just in the management of temperature, but with the associated fever, you have an increased metabolic rate, so reduced blood glucose levels. An increased metabolic rate means a reduction in or an excess of consumption of oxygen and an excess consumption of fluid. So assessing for circulatory status, hypoxia and hypoglycemia becomes important for these patients that are particularly febrile. You can examine for rashes, watch respiratory rate. Not always is a rash going to be present. You should be assessing for it, though, as part of your history and assessment for that patient. Obtain vital signs, ensure adequate oxygenation and ventilation. Do not actively cool the patient, but do not keep the patient bundled up if they're excessively warm, right? You don't need to strip the patient down to nothing and expose them to cold water or something like that. However, caretakers, moms, dads, caregivers, grandparents, would like to keep baby bundled up. And if baby is hyperthermic or running a fever, then baby needs to be unbundled. Keep clothes on baby, but you may remove a hat. You may, unbundle some of the blankets to allow more evaporative or conductive cooling. Hypothermia is a drop in body temperature below 35 C or 95 Fahrenheit, and newborns, again, are sensitive to environmental conditions, especially right after delivery. If we're in neonate world and patient is hypothermic, use that as an indication for potential infection as well. Remember that their immune system is just not up to par just yet. Hypothermic newborns can be pale with acrocyanosis or cool to the touch and may have decreased respiratory rate, effort. Bradycardia isn't uncommon in the hypothermic, as well as sclerema. Preventative measures include warming your hands, drying baby after birth, placing pre-warmed cap on the head, keeping baby warm. Baby has to stay warm. If newborn is hypoglycemic, right, dextrose 10% are going to be our medication of choice here. Once stabilized, placed in a pre-warmed incubator or on mother's chest. We don't have the luxury of pre-warmed intubators in most of the pre-hospital world, but mom is a great incubator, and so utilize the body warmth from mom there. We're going to go through a handful of birth injuries here in the newborn. Most of these are self-limiting, but it is something that you need to be aware of. Newborn injuries can occur because of newborn size or position during delivery. We talked about things like cephalopelvic mismatch, where a baby's head is too big for mom's pelvis, and brachioplexus injuries that may be common with shoulder dystocia. Here are a few others to be mindful of. Malformation of the head is not uncommon. It's a normal process. The head, so the image on the right-hand side of your screen here, when the cranium passes through the birth canal, the sutures that aren't present yet, the fontanelles or the soft spots that are in baby's skull, allow for the manipulation of the skull around the brain to facilitate passage through the birth canal. So it's not terribly uncommon that we could see some malformation of the cranium. That usually resolves within a couple of days. But if baby is persistent and vigorous and moving along well post-delivery, there's really not anything of any concern here. It may be common for you to experience, if you respond out to a newborn or a neonate rather, that's been discharged from the hospital, you're going through an assessment, it's not uncommon to see deformities to the cranial vault as well from tools used during delivery. So things like forceps, tongs, suction devices that were used to assist in delivery there. You do need to inquire about these things, because hematoma, secondary to trauma, can be very similar in presentation to some of these normal cephalic defects that occur during delivery. Other common birth injuries include things like brachial plexus injuries. Again, this is shoulder dystocia. We talked about the management of shoulder dystocia to help prevent damage to the brachial plexus, but it's not uncommon. Facial nerve palsy, diaphragmatic paralysis, laryngeal nerve injury, spinal cord injury. Birth is a traumatic thing for both mother and baby, so injuries can certainly occur. The clavicle is also, while fractures aren't common, the most common fracture during childbirth is the clavicle. And on examination, you'll have a palpable bony irregularity of the collarbone there. There may be a lack of arm movement. There may be crepitus, of which assessment should be noted, right? And that information should be conveyed to the receiving facility. Long bone fractures may also be present, and it may present as a loss of spontaneous arm or leg movement. Intra-abdominal injuries and thoracic injuries are relatively uncommon. We have talked about things like pneumothoraces, but those are less common, and intra-abdominal injuries are also pretty uncommon. Hypoxia and shock can be caused by birth trauma, so just make sure you're assessing accordingly.